This week we're going to have a look at culture and organizational culture within healthcare in Canada. We're also going to touch on another way that power is used, and that's through medical discourse. So we're going to start our discussion today with a look at culture. Culture generally refers to the values, beliefs, knowledge, art, morals, laws, and customs that are acquired by individuals and groups. Think of it as the built-in software that influences perceptions or the ways of processing information and interpreting the world around us. Let's reflect back to our first class together when we were talking about the transmission models of communication. Remember the powerful role that noise plays in creating distortion? Culture is certainly part of that noise. Verbal and nonverbal messages and meanings are more difficult to interpret when people are from different places or have different cultural experiences. So if we're focused on becoming leaders in Canadian healthcare organizations, we really need to understand Canadian culture. What is it? Molson Canadian, a beer company, launched a commercial just before the National Hockey League playoffs in 2000 called I Am Canadian. It's the rant, and it talks a lot about the land being about Mounties and lumberjacks, hockey, and maple syrup. But are we more than that? How much more are we? I've attached a link to the commercial so that you can see it yourself. Nonviolence and tolerance of others are certainly things that are highlighted in the rant, and they also tend to be quite descriptive of the Canadian culture. Most Canadians have habits and beliefs similar to those of other Western, technologically advanced societies. Canadians tend to be more collectivists than our individualist neighbors to the south. We have the idea that a group or nation is more important than its individual citizens. You can see this through the way that our Medicare scheme is organized. Canadians also place less emphasis on tradition, ceremony, and social rules than some people in other countries. We tend to dress more casually and are on a first-name basis with others. We are often direct in our business dealings, particularly in healthcare. We feel that indirectness is a waste of precious commodity of time. We're straight shooters when it comes to communications, straightforward and suspicious of evasiveness. We distrust those that we suspect may have a hidden agenda. We're also uncomfortable with silence and impatient with delays. Our use of words and understanding of them is also quite literal. We equate time with productivity, efficiency, and money. Our society believes that keeping people waiting for appointments wastes time and is rude. This creates significant challenges for healthcare leaders and staff. So as leaders in our organizations, there are a couple of things that we really need to watch out for. These are the barriers to understanding and accepting people from other cultures. The first is ethnocentrism, which is the belief in the superiority of your own cultural group. This attitude is found in all cultures. It causes us to judge others by our own values. Bear in mind that others won't necessarily react as we would expect them to. Learning about other cultures and developing flexible, tolerant attitudes can help fight ethnocentrism. Stereotypes, the oversimplified behavioral pattern applied to an entire group, is another barrier. Stereotypes may not accurately describe cultural norms, or more importantly, the person that you're interacting with. Be on the watch for your own opinions. Look beneath the surface of stereotypes and labels to discover the individual personal qualities. Remember how we talked about walking a mile in another person's shoes earlier, about empathy? It's also key to developing intercultural tolerance. Being empathetic, non-judgmental, and patient will help you see the world through another person's eyes. Recognize things as they are, not as you believe they should be. So, how is healthcare culturally influenced in Canada? Cultural institutions, such as hospitals, are state-controlled through regulation and funding. While Canadians may identify with Medicare as being socialized, it's only part socialized. For example, doctors work in private practices, and their offices operate much like any other profit-driven business. But instead of issuing invoices directly to the consumer, provincial governments or private insurance companies are billed. In 2004, decades after the establishment of Canada's Medicare system, Canadians voted Tommy Douglas, the architect of the system, as the greatest Canadian in a television show called The Greatest Canadian. This demonstrates how Canadians have woven the discourse of healthcare into their national identity, even though they may spend several hours waiting to receive care in their local emergency department. Healthcare is a source of pride for Canadians, and it's something that sets them apart from their American neighbors. Healthcare is a top issue in virtually every federal or provincial election, and it's discussed broadly in our homes and communities. Just like we have a culture as a nation, our organizations have their own individual cultures. In many of your workplaces, you've likely undertaken staff cultural surveys. These are also referred to sometimes as engagement surveys. Our workplaces are entities focused on making decisions, coordinating activities, and solving problems. Each of these processes is shaped by organizational values and norms, which are rooted in the specific languages and practices of the organization. Organizational culture scholars study the language, symbols, and rituals that are unique to organizations. You have a link for reading Edgar Schein's book. Edgar Schein is an amazing theorist and researcher, and he purports that any culture can be analyzed on 3 levels, and he uses the concept of an iceberg to illustrate his argument. Schein says the most fundamental level is that of the underlying assumptions. These are things that the members of an organization see as the truth. It's a level where he says culture is almost blind to itself. Although these assumptions may change over time, they're rarely discussed explicitly. These may be the beliefs, such as the organization being controlled by the invisible hand, or that employees need to be controlled to work hard. This is the essence of a group's culture, and is the pattern of learned, shared, taken for granted assumptions that are the ultimate source for values and action. The next layer in Schein's model are the espoused values and beliefs. This is more self-aware. There's more self-awareness at this level. These are things that are talked about, confirmed, or challenged in terms of the strategies and goals of the organization. Some examples may be efficiency, flexibility, service-mindedness, and ethics. Finally, the third level of culture, the most visible and tangible level, and one that we often are helping to build and shape as communicators, is that of the artifacts. These are the things that people see physically: the buildings, the dress, the decor, logos, rites, rituals, ceremonies, stories, and jargon. Together, the assumptions, espoused beliefs, and artifacts constitute the complex phenomenon of culture. Assumptions shape the values that are reflected in the artifacts, but the reverse can also be true. New artifacts, maybe a computerized order entry system, for example, can help reshape organization values and, over time, be incorporated into new assumptions. We spoke earlier about medical discourse being part of an organization's culture. It's certainly embedded within healthcare organizations and plays a significant role through the use of power in political, social, and cultural aspects of our workplaces. Communications theorist Michel Foucault and others have shown that medical discourse involves a struggle for power within medicine, and medicine being an institution for social control, with the body serving as a site for surveillance and control. The discourse that's used by professionals in communicating their special knowledge, so the special language that we use as doctors and nurses and other healthcare professionals, enhances our ability to intervene and to control the behavior of others. And it's particularly true within the medical fields. In fact, health professionals may not be conscious of the impact of their actions, but the clinician-patient encounters may reinforce the social order by focusing on individual troubles rather than the social issues. So as social constructs are being reinforced without conscious awareness by health professionals, it can be assumed that there's an opportunity that communication can potentially bring about change just by us being more explicitly aware. So the struggle for power manifests early in a medical encounter, quite literally when someone enters the medical space. The individual is labeled as a patient from the moment of their arrival, even if they're not sick. The Latin root of the word patient is pati, signifying suffering or enduring. In 1997, Barbara Scharf concluded that the term patient connotes a stance of passivity or helplessness, presenting the patient as a compliant recipient of biomedical services. She concludes that the etymological symbolism of the term seems to work against a revised notion of a person with health concerns who strives to form a more collaborative partnership with their physician or clinician. Are there any fans of House out there? Although Hollywood, House is a great example of how medicine has become more and more technical. Typically, he treats his patients with disdain, which may not be the truth in practice, and even in a few episodes refuses to go to the bedside. Instead of relying on them to share their stories, he relies on a vast array of tests to come up with his diagnoses. But instead of castigating Dr. House, I've chosen a clip that's linked from the Blackboard area that is a bit different and provides us with some food for thought about the importance of clear communication. And with that, I will leave you to enjoy Dr. House.